All right, my clock says 12 o'clock. I like starting on time. So good afternoon, and thank you for joining us for the fourth session, the fourth and final session of the 2022 Older Adults and Opioids webinar series, hosted by the Finger Lakes Geriatric Education Center. We are a HRSA-funded geriatric workforce enhancement program at the University of Rochester, and our co-sponsor, the Western New York Rural Area Health Education Center, also a HRSA-funded education center. My name is Laura Robinson, and I am the program coordinator for the FLGEC. My co-host today is Christine Chappell. She is the administrative coordinator with the Western New York Rural AHEC. We are so glad you could join us for our third year of hosting this series. We also welcome our interpreters for today's session, Michelle Bem and Alex Vasey. Thank you so much for being with us. And a few housekeeping items before we begin. There are two important buttons on your Zoom toolbar. Please use the chat button to type hello and introduce yourself with a name, job title, agency, and location. We have people from across the country joining us today. I scanned the attendance list or registration list. We have people from New York, Oklahoma, Tennessee, and Pennsylvania. Also, let me know if I skipped your state and add that to the chat as well. But usually we're international, but today just a few states with us. The Q&A button on your toolbar will allow you to type in a question for the presenter. We ask that you use this button at any time during the presentation to ask a question, and our speaker today will be happy to take that question at that time, or we can save them for the end. And we will definitely leave time for questions at the end. So now I'm just going to go through our CME and social work disclosure slides for you. And so this is the title and learning objectives for our session today. We are accredited for 1 CME credit and 1 social work credit with this session. None of our planners or presenters have any disclosures. And I will send you an email following the presentation which gives you instructions on how to claim your CME and social work credits. Social workers must attend the entire session in order to receive any credits. And no commercial funding was received to sponsor this presentation. Everything is grant funding from HRSA. So thank you, HRSA. So now I will invite our presenter to please share your screen while I introduce you. So today's presenter is Charlotte Crawford, who is a retired Chief Executive Officer from Lake Plains Community Care Network. And she just told me before we started that she has a brand new job. So maybe she'll tell you about that as we start. So that's not included in my bio. So retirement didn't last long for her. So she joined Lake Plains in November 2000 as the Care Management Director and became the Executive Director in April of 2006. Her responsibilities over the years have included grant submissions and oversight, creating partnerships and chronic disease initiatives for Orleans, Genesee, and Wyoming counties. In 2007, she led the initiative for LPCCN to become the Big Lakes Emergency Medical Services Program Agency. And this program initiative focuses on assisting emergency medical services in Niagara, Orleans, and Genesee counties to meet New York State requirements, provide education and other services identified by Big Lakes and the EMS agencies in the region. Charlotte has always been involved in healthcare, serving as a nurse in various capacities and as a paramedic for 43 years. Charlotte has been an educator in both volunteer and professional environments. Now in retirement, I don't know, I think I have to change the sentence too. She will continue to work as a nurse in the medical office part-time, volunteering at her local fire department and working in her church's clothing closet. In addition, she will continue to teach Narcan classes, CPR and first aid, and other topics as requested. She hopes this will keep her from becoming bored, and she's not going to be bored. And we are very honored to have you with us today. And I will now turn the program over to Charlotte.
Okay, thank you guys so much for coming on and listening to all this. And she's absolutely correct. I did not truly retire. I am now the executive director for a comfort care home in Genesee County. It's actually in Batavia. It's called Crossroads House. If anybody wants more information on that, they can give you my email, and I'm more than glad to share anything you want to know about it. But I'm here to talk about Narcan today, and that's exactly what I want to get doing. And as she said, I'm almost done with Lake Plains. I'm retiring from there. I am a New York State paramedic, have been for, as she said, a long time, which has driven me to make sure that EMS actually has the tools and the knowledge they need in order to treat overdoses appropriately. especially since New York State has made it easy enough for us to do this. Okay, as in a lot of the objectives, you're going to learn the signs and symptoms of an opioid overdose, and they're pretty simple. At least they're very simple when I teach them to the EMS providers. I don't want them having to delve too deeply. If you're familiar with the Good Samaritan Law that works with CPR, this one's a little bit different, which is okay. The use of Narcan, how you're going to use it, and reporting and follow-up, which may be different in the state that you're in. So this is something you're going to want to look up. In our area, we like to get the data so that we can use the results to go for further grant funding. This program allows anybody, absolutely anybody, to administer Narcan. I have trained people in their 70s and 80s because of loved ones. I have trained 12-year-olds because of the need within their family. It's 100% funded from a grant from New York State, from the AIDS Institute. I'm not paid to do this by them. All they do is provide the Narcan that I distribute. So that to me is huge. That's my primary concern. Now, this actually took effect in 2006, the ability for people to give Narcan. There was a huge increase in opioid overdoses. Heroin was out on the streets. But I'm going to tell you, back in 2006, we did not see, as a EMS provider, the overdoses like we're seeing now. The problem in 2006 with being able to give this was EMS was limited as to who could provide it. The only ones that could were like paramedics. Basic EMTs could not, because the only way it could be given was by needle, and they're not allowed to give a shot. It's out of their scope of practice. There was a chance to get a grant back, I believe it was in 2015, where okay, I argued with the state. I wanted to be able to take the needle off and put an atomizer on it. But unfortunately, the FDA had not approved that yet, so we didn't bother to go for the grant. I couldn't make it accessible for my EMS providers. Since then, they've made it so that we can. The majority of the overdoses, as it says, are not witnessed, which causes a problem for getting either intervention to prevent the overdose or getting them help. People don't call 911. They're afraid of calling 911. Many people who are with the ones that are overdosing are people that are on parole, have an outstanding warrant, or something else going on. So they don't want to call. I tell people, if you're in that boat, just call, administer Narcan if you have it, put them on their side, leave the empty Narcan there so that we can know that you've given it, and then you're not there when the police show up. May not sound good, but at least they're going to do something. That's our hope. There are people who have done things that are totally, totally useless. I showed up on a scene one time where people were walking it off, dragging the person through the yard as they're not breathing effectively because they thought if they did that, it would wear off. And there's other things that they've done as well. As I talked about doing something and leaving, that's perfect. My biggest fear is people will say, oops, I got to get out of here. And they just leave them. So we have been doing Narcan now since approximately 2016, 2017, when we started training. Well, 16, we started training on how to use Narcan and why. And we've seen ups and downs with it. The biggest problem we saw was COVID, which I'm sure a lot of people have seen. COVID really, really hindered a lot of good effects that people had by going to counseling and different groups that they would meet with, because they were all cut off. They couldn't do one-on-ones, they couldn't meet in person. So that really hurt the whole program. People were dying again. They couldn't do what they had to do. But with this, respiratory is the biggest problem with an opioid overdose. People stop breathing. When they don't breathe, they become hypoxic, and it can cause brain damage, and it can stop the heart, and they will eventually die. Narcan is the only one that's recognized as an antagonist for it. This is one of my favorite slides because it shows that anybody and everybody stands at risk for having an opioid overdose. Nobody wakes up in the morning and says, I know what I want to be today. I want to become a substance use disorder individual. I want to have a problem with opioids. That's what I want to do. Nobody does that. So you have people get introduced to it and then decide like, you know what, this is pretty good. I feel pretty good. And those are the ones who get the pain meds, and then they start looking for them. Experimentation with the kids. The ones I've seen frequently are the longtime users that have gone through rehab for a while or been incarcerated and come out. And then they have the same friends they used to have before. And they say, hey, one more time for old time's sakes. It doesn't work that way. I've picked up a few people that have done that. And they either say, take me back to rehab right away, or they make up stories as to why it happened. But most of them want to go back. This happens everywhere. And I will be honest, we've picked up, there's no category. I've picked up individuals that are cops' kids, teachers' kids. It doesn't make a difference. I even picked up a pastor's child one time. And it was that, some of them are not intentional. Sometimes it's just hanging out with the wrong person. I'm going to show you some data from our area. I know it's not going to mean a lot to a lot of you, but I'm willing to bet you have comparable data. This represents the opioid overdose death data for what's Genesee, Orleans, and Wyoming County is the GAO region. And you can see we started getting some data in 2010, and I'm going to apologize. They stopped collecting the data in this format as of 2019, again, COVID. But you can see we started getting a huge increase in 2017 with overdoses and deaths related to opioids. Now here's putting it in comparison apples to apples by doing overdose per 100,000. And those of you familiar with this area, the two bigger counties we have around us is Erie and Monroe County. And in 2017, Genesee County had 36.2 per 100,000, which exceeded what they had in Erie or Niagara County. Not Niagara, I'm sorry, Erie or Monroe County. That was an eye-opener for us in our region. We figured bigger cities would always have a bigger problem, and it wasn't true. So it made us hopefully start doubling down on our efforts to train. We do collect Narcan administration. This shows you the Narcan that was administered, which is kind of sad. But we have to remember the only way we get this data is by people reporting on the forms that we distribute to them. They don't all do that. I'm very fortunate. We get them from law enforcement primarily, some EMS agencies, generally the bigger ones. I even have hospitals sending me data now. So this is great. We're able to get some data to put together and have an idea. This is kind of a rough one because it just tells you overdose categories in the emergency room, and it can be anything. It's not just Narcan, not Narcan, I'm sorry, opioids. This could be an antibiotic, it could be Tylenol, it could be anything, but this is just categorized as an overdose. Okay, you can see, this shows how many people participated in the Narcan training in our GAO region. You can see in 2017, we didn't have a whole lot of people. The one thing I've noticed, which was 2016, things came out, people wanted to learn. 2017, people stopped requesting as much. We were getting bad attitudes, I call it, because people were, if they want to die, let them die. But then it started hitting home to people and they saw the data that, this isn't going to work. So in 2017, bad numbers, 2018, the numbers picked up. So we definitely made an impact by being able to tell them about the numbers of people that had died from an opioid overdose and really opening some eyes. Now, some of the problem with the opioids is the I-Stop law. And I don't know how familiar many people are with this. It's a New York State prescription monitoring program. Essentially, any provider has to consult this program before prescribing an opioid or any controlled substance, essentially. This is all kept, it's real-time data. So if somebody comes to, say, the hospital and says, I'm in pain, I need my Oxycontin or whatever they like to take for pain, they will look to see if they've recently received a prescription for that from any place else. And if they have, then they will not give it to anybody. It's not going to happen, which makes people upset now, but that's okay because now they're not going to be able to get too many. Now, the one thing I like is this. You can see where they implemented the iStop program, where it was implemented, but this only illustrates the people that receive the prescription from more than 5 practitioners and dispensed by greater than 5 pharmacies. I worked in the ER for many, many years. We used to get a lot of people coming in after hours, after the pharmacy closes and doctor's office close, and say that they are having excruciating pain and this is the only medication that works. So if you work in a hospital, they look at your scores as far as pain control and everything else. So they were very good about controlling pain by giving them pain medications, prescriptions. After a while, we started doing like a 3-day supply, and then they'd have to go to the pharmacy where they could check to see if they had a script. But that's why they were bouncing to different pharmacies. There was no way to compare. This came in, this changed everything. They could compare, pharmacies talk to each other. There was a central data system, cut way down on the doc shopping and the misuse of the emergency room and going to multiple pharmacies. This slide, I always tell my providers, I said, make sure you memorize this because you need to know what they've overdosed on. I'm lying. I don't want people to study this. It's not important. You're not treating the drug. You're treating the symptoms. It throws people because they're always like, what did they take? Don't care. We don't care what they took. You're treating the fact that they're not breathing effectively. They're unresponsive. That's what we're treating. So what usually happens, usually is the key word, is over an hour to 3 hours, you'll start seeing the symptoms. The real simple ones are they'll slow down their breathing, they'll become unresponsive, the breathing gets shallow enough that they stop breathing, and then the heart stops. If you have somebody who's used fentanyl, that death can be very quick. When my reports come in, I can almost tell you what their toxicology will come back as when they say needle found in the arm. That's going to be a fentanyl overdose. Heroin is nowhere near as bad as fentanyl. It sounds strange to say, but it's not. It doesn't kill somebody as quickly. So you got a longer period of time where you can make a difference in treating them. Oh my goodness, what did I do? Oh, okay. Sorry. So like I said, it doesn't happen quickly, but they usually start off with heavy, uncontrollable nodding, which may or may not be what you see. You may see somebody who's easy to wake up a little bit. Okay, they may have those other symptoms. But once they hit the overdose, they're not responsive at all. Their breathing is very shallow, or they may have a gurgling because they can't really maintain their airway. And then when you start seeing them going cyanotic, or their skin changes, blue lips, nails, they are very close to dying. So we need to do something quickly. This is a different way to look at it. Okay, the opioids decrease the urge to breathe. So the breathing slows down, carbon dioxide levels come up, oxygen levels decrease, breathing stops. Lack of oxygen to the brain can cause brain damage. The process does take some time, but once the heart stops, if we don't get in there quickly, they're going to die. I have had people suspect an opioid overdose in cardiac arrest. There's only been a couple of them because if you don't get there quick enough, they've actually given the Narcan, started treating them, and they're actually brought them back. So it's not too late to try. Now, Narcan is an antagonist for an opioid. It can be given either injectable, IV, or intranasal. I've been a paramedic for a long time. I used to do IV and injectable all the time. Works quite well, very quickly, but not a lot of paramedics around. This blocks the opioid from acting on the body, but it's only works for like 30 to 90 minutes. I like the analogy of it stealing the parking place. It stops the opioid from attaching to the receptors, which this next one shows, because it binds to it. Now, only works for 30 to 90 minutes. So you have to either take them to the hospital in case the half-life is longer, or they have more drugs around that they're going to take. You never want to leave somebody home where they could take another dose. And you want to make sure that this is working well for them. The Good Samaritan Law that we talked about, this one is different from CPR. This one encourages anybody who's there on the scene to do the right thing and call for help. It also, as you can see, if you read the list, there's protection from some of the charges that somebody could get in trouble for. And this is part of the reason why people don't like to call for help, because they're always afraid they're going to get in trouble. Now, on the flip side of that, there are things that they can get in trouble for. It doesn't offer protection against the following offenses, and I'm not going to read them to you. If they have an outstanding warrant, or they're on probation, or parole violations, that kind of thing, or other drug-related crimes, they can get into serious trouble, and they know that. These people know, they know what's gonna break the bank for them, and they're gonna get in big trouble for, and they're gonna run. That's why I tell them, administer the Narcan, leave it there, and then beat feet if you have to. Roll them on their side in case they throw up. This, if there's some night you can't sleep and you want to read this, feel free. This is the penal law that the Good Samaritan Law is under. That's the first part. And there's the second part. There's also a public health law that comes with this. This one allows any non-medical person to administer the Narcan, and there's no liability for it. One of the biggest arguments I've ever gotten into at a class was with a nurse who told me they couldn't do it without a doctor's order. And I asked them, did you do CPR without a doctor's order if you had to? Well, yeah, that's different. No, it's not. This is first aid for somebody who's overdosed. It's not a problem. You can do it. And it's tough when you don't know if you can or not. I always err on the caution of the person who's laying in front of me who needs the help. Now, I include this slide only because it may still be out there, but I do this, like I told you, my primary audience is fire and EMS and in the community. So I always tell them, if you see the vials there, look for a needle. We don't want anybody getting a needle stick and having problems with that. So I always tell them, if you see the vials, watch for a needle. We don't want you to get hurt. Not that I've seen this out for a few years, although initially we were having our EMS providers going to these classes because they were so desperate to learn how to help someone, and this is what they were being given. I had to call the people that were training them and say, please don't give them the needles. They can't administer it. They'll lose their certification. I said, send them to me and I'll get them the stuff they can use. And at that time it was this. This is 2 milligrams. You would put half of it up one nostril, the other half up the other, but you had to remember to put the atomizer on. And that was the biggest problem when people were doing the Narcan. They'd forget to put that on. And without the atomizer, it wasn't being misty. It wasn't made into mist to be better absorbed through the nasal mucosa. Now we have this. This one is beaucoup easy. You can't mess it up. This is 4 milligrams. So right off the top, that's double the dose you were getting with the old one, which they found to be much more effective, especially since there's more fentanyl coming out, or actually in use, and you need higher doses of the Narcan anyways. And after a while, you can only give so much Narcan to the nasal mucosa before it stops being absorbed. And then you need to do IV. So since the nose is the easiest point of access, it's the easiest place to do it. Nobody gets hurt. There's no risk of needle stick, and there's no fear. Most people do not want to stick a needle in somebody. So this made it a lot easier and much more accepted by people who want to help. This is just a picture of the nasal mucosa with the old atomizer. So you can see how it's absorbed to a large area, highly vascular area, absorbs quickly. When you give somebody this, they can start coming around within 1 minute or less. if it's a true opioid overdose, depending on what they've taken. There's been times where I've seen people get up to 3 doses to get them to come around. But generally, heroin overdoses, I'm going to tell you, come around much better than fentanyl does. This is how you're going to hold the atomizer, the dose. It's, don't prep it. You only put your fingers there, hold it there, put it into the nostril, and depress the plunger. If you push it beforehand, you've lost the entire dose. So never test it. Just put it in the nose and then push it. And you only have to do one side. You don't have to do 2. You can switch it up. So we're going to talk a little about how to use it. Back to the picture. So the signs of an overdose: the person will be unresponsive. You can't wake them up. You can shake them and yell at them, and they're not going to wake up. The breathing is really slow. They may be making the gurgling sounds or a sound like they can't catch their breath because their airway's a little blocked, and their color is going to be off. I tell people open the airway because that may help if they're even trying to breathe, but they need the Narcan if it's an opioid. So you're going to shout, shake them, try to wake them up. If there's no response, it says grind your knuckles in their chest bones for 5 to 10 seconds. That hurts. People are going to respond to that. If they still don't respond, call 911 right away, even before you give the Narcan. Everybody has a cell phone now. Take your phone as soon as you find somebody unresponsive, dial down 911, tell them what you think you have. If you're not sure, just tell them it's an unresponsive person. Don't care. They'll start getting help right away. The quicker you get people responding, the quicker they get the help, especially if you don't have the Narcan. So if you think someone's overdosed, tell them you think someone's overdosed. 2 reasons there, at least in my area. If you call in an overdose, we're going to get law enforcement and you're going to get EMS right away. And our law enforcement carry Narcan. All of them carry Narcan so that they may be the first ones on scene that can treat these people. It's important to get that on board as quick as possible. Here is the biggest thing I like to really stress. If you're going to carry Narcan, you need to know how to do CPR. You really, truly do. If the Narcan does not work, you need to know how to get that person breathing again and their heart as well if they don't have a pulse. I'm not saying you have to know how to check a pulse or anything. Bonus if you do, but if they're not breathing, you're going to breathe for them. So this, if you don't have CPR, you tilt the head back, pinch the nose, and then you're going to give them a breath. I'm a firm believer in always having a barrier between you when you're doing CPR. So if you have it, use it. In my Narcan kits that I distribute, they have little face shields. It's not a lot, but it gives you a barrier between you and the person. That makes it a little bit safer for you. So when you give the breath, you want to see the chest rise. You only want to give that breath to see the chest rise. Never breathe more than once that chest goes up. Okay, you're going to keep doing that as long as they have a pulse until help arrives or they start breathing on their own. So if you give the Narcan and the person wakes up, make sure you let them know what happened. I'm going to tell you, people are very confused when they wake up. They may wake up agitated or upset, and could be very mad. I've had, I'm trying to think how many, a lot of reports given to me, well over 1,000, I believe. And I can count on 2 hands only the number that woke up agitated enough and swinging where somebody could have gotten hurt. Most of them are kind of groggy still, and you don't have to worry about getting hurt. But you do want to be safe just in case. And you also have to remember, it wears off in 30 to 90 minutes. So you stay with the person until the ambulance comes. You want to make sure they don't overdose again. Narcan can be repeated in 2 to 3 minutes, which is important to know. So if you get them, they aren't quite coming around, you can give them another dose. When the ambulance gets there, make sure you tell them how much you've given, how they responded. And if you have any other information on the person, make sure you know that. If you need to leave, and this I stress, is you lay the person on their side to prevent them from choking. One of the side effects can be the person throwing up, and we don't want them to do that and aspirate. I really push the fact that people need to encourage the person to go to the hospital. In our area, again, this is where they're going to get their first introduction to any help. We have a very excellent program, actually, of peers that will come out and meet with the person who's been taken to the hospital. Our peers are actually people who are in recovery, and they will stay with the person, get them the help they need, meet them where they're at. And by that, I mean not physically, emotionally, socially, psychologically, where they're at. If they're ready for help, they will help them get the help. And it may not be getting help for their addiction. It may be, I have no place to live. I don't have food. So they meet them and get the resources that they need. And sometimes that's the first step to getting them to the help for their addiction. Those are really important programs. We have the PARI program, which is where they can go to any police. Well, there's certain police agencies in Genesee County and some in Orleans and Wyoming where they can go and say, I need help. I'm done. I use these drugs and I need help. I want to get help. I want to get help. And doesn't make a difference. If you have outstanding warrants, convictions, anything like that, that gets waived aside. They'll get you the help you need. No questions asked.
Charlotte, it's Laura.
Yes.
There is a
Yes.
comment in the chat from George, who's also an EMT, and he says New York State collaborative protocols say repeat once in 5 minutes. So 5 when on duty and 2 to 3 as a layperson.
I'm gonna tell you how many people really watch their watch, but and that's where some of the problem comes out. The providers of Narcan say 2 to 3. New York State says 5. So whichever you have to stand by, George, I would go by that. Everybody else is being trained 2 to 3. So if somebody says they gave one and they gave it another dose 2 to 3 minutes later, don't yell at them. That's what the Narcan provider, the pharmaceuticals are saying. Okay, does that help?
Yes, he said thanks.
Okay. Okay, if the person wakes up, make sure you lay them on their side. Again, this is to prevent any potential for them to aspirate if they throw up. Always tell them, please don't take anything else. Don't leave them. Make sure they get help. And I'm going to tell you the number one problem we have as providers is they'll sign off. They can sign off and refuse to go to the hospital, which is sad because then they're not getting the help that they need. I've only had one person because I'm an ag and I will work with them until I can get them to go in and get them the help that they need. And I know we've had providers say they go to the hospital and the doctors say, oh, you're bringing them here for what? They've been reversed. Don't care. It's not about that part. It's about getting them the help that they need. Okay, there are side effects. And I'm going to tell you, if you're in the field, chances are you are not going to see any of these. These are going to be longer once they get to the hospital, except possibly the nausea and vomiting. The rest of it is not going to happen in the field. But the bottom line is, if they're not breathing, the rest of that stuff is meaningless anyways. You need to help them start breathing again. We don't care what they took. We don't care if it is street drugs or prescription. We suspect things if it's situational. If you go someplace and you see drug paraphernalia laying around, again, this is EMS that I primarily teach. You're looking at that, you're going to unfortunately assume that this might be the cause. If they're hypoventilating, not breathing well enough, or they have respiratory depression, you're going to assume that it's an opioid overdose, and it may not. And this is another thing I tell my EMS providers is every time you have somebody who's not breathing well or having a problem, it does not mean it's an opioid overdose. It could be another medical problem. So if a Narcan doesn't work, look beyond that and treat the other symptoms. So again, it doesn't make a difference if it's street or prescription. They both can be reversed with Narcan. Just does not make a difference. It's the same kind of drug. So you have If it's not an opioid overdose, it's not going to hurt them. You'll get a wet nose. That's it. And nobody cares about a wet nose. You've given them the chance. This is a really quick review, guys. Overdoses, again, rarely happen immediately unless it's a fentanyl. They're still arousable. And I'm going to tell you a quick example is there was a student in school, good student, straight A student, worked, just a good kid, had gone to school, and she sat next to a window, and the teacher saw her put her head down after she'd been there about 15 minutes and said, oh, she probably worked last night. She's probably tired. So she didn't bother her. She left her alone until the change of classroom bells went off, and she didn't wake up. So she went over to wake her up, and she was dead. She'd overdosed. So I tell my students as a sidebar that if they fall asleep, you're lucky I can't see you, that if they fall asleep, I'm going to think that they're an overdose. And they may get Narcan if they're not breathing well. But anyways, we want to treat them before they die. Now, here's what I'm going to tell you. This is what people in my area do. We give them the forms to report so we can collect the data. I have them return them to JACASA, which is Christine Ferraro. That's her email. And when they do that, they get a replacement kit. It's like my little carrot that I dangle. I also replace expired stuff. And if they forget to do it, I don't care. I just want them to have the Narcan in their hands. But this is what we do to get the data. And I really encourage people to do that. Now, you need to store Narcan at room temperature. Now, it's really tempting to stick it in your car and keep it there because that's where it's easily accessible. You don't want to do that because in the summer it's too hot, at least in my area. And in the winter, it'll freeze and you're not supposed to let it freeze. So you want to keep it someplace. I tell women, throw it in your purse. Men, I don't know what to tell you. I have guys that have little bag type things. The law enforcement, they have their duty bags that they keep things in. Protected from light, and it does have an expiration date. So make sure you're aware of when it is and make sure you have an ability to get more before it actually does expire. This is something that I want you to know. See that little tiny speck of white stuff? That's a little tiny bit of fentanyl that if you inhaled that, you would overdose. It could potentially kill you. This is why it's so important to be aware of your surroundings, especially if you're going into a situation where you have a situational area where you think maybe it could be, drug paraphernalia and whatnot. You never know what you're getting into. Always wear gloves when you go in. And I also tell people, if you go into something like that, change your clothes right away when you come out. And this is a true story, happened, I'm not even sure where. There was a car that had kind of drifted off the side of the road, no accident. The woman in the front seat was unresponsive. Law enforcement pulled up, pulled her out of the car, put her on the ground, realized she was probably an overdose. She wasn't breathing well, or actually she wasn't breathing, gave her the Narcan. EMS showed up, took the patient. He looked down, he had a little bit of white spot on him, said, what the heck? Went like this, brushed himself off. And next thing he knew, he was in the back of an ambulance, unresponsive. Well, he woke up. They gave him the Narcan because they figured out what happened. But I want you to think about this. What if he had not done that and he'd gone home and he had an infant at home and he picked up that infant, cuddled the baby at bedtime, and then laid the baby down either for a nap or for the night, and the baby never woke up? This is why I always tell people you have to protect yourself. And you need to take care of those you love. And the best way to do that is wear masks. If something's aerosolized, definitely wear gloves. I tell people always wear gloves when you're in that situation. Safety glasses are nice because your eyes are mucosal membranes and things can be absorbed from them as well. And wash your hands with soap and water. Do not use alcohol wash. Anything with alcohol will increase the absorption. You don't want to do that. So you wash soap and water only. Remove and clean your uniform or clothing always, because you do not want to take anything home to your family or anybody else that you love and care about. So the other thing we talk to people about is the NCAP program. NCAP program is in New York State. I know this. I don't know if it's anyplace else. It's going to be something you want to look at. I don't even know if it's countrywide. So if anybody's on here that knows that, that'd be great, because I don't know. In our area, if there's a standing prescription, you can walk into the pharmacy and tell them that you would like to buy some Narcan. NCAP will cover to $40 in your prescription copays, and you don't have to pay anything if it covers the entire amount. So this is nice. So if you have a loved one who's on maybe an opioid prescription and you want to have something just in case, and I'm going to tell you it would be handy, especially if you have, and this is a scenario that I had happen to me. A few years ago, I got a call for a woman who was she was end stage cancer, and she was on fentanyl patches. Family thought that was her time. I don't know why they called, because they thought that was her time, except for the fact that she was absolutely fine in the morning, just had some pain. So they called for help, because it was weird that this would happen like this. We get to the scene. I have the family are all arriving, and the one daughter goes, I don't know what happened. I was just here. I changed her patch. Another daughter looks there. She goes, oh my gosh, I stopped in. I did the same thing. So now this poor honey had too many patches on. That's what caused her overdose. We had to give her some Narcan in order to reverse it. The problem with that is it puts the person into irretractable pain, because now it's taken away all the opioid that's supposed to help her with her pain. And again, it lasts 30 to 90 minutes. So now she's got the longest 30 to 90 minutes of her life before they can start helping her again. So anyways, the NCAP's a great program, at least for people in New York. And like I said, I don't know of other areas if it runs. And then we are just about winding up here. This is my contact information, but I will tell you that's my present one for the next week. The cell phone is still good. And the email at the bottom, it says Charlotte Crawford 2017. That is my email that I'll be switching to once I am totally gone from Lake Plains. And if you do, I encourage you, if you have any questions, feel free to call either my cell phone or email me at that other email, and I will reply to you. So if you guys have any questions or anything, please let me know. And that pretty much concludes my presentation.
Thank you so much, Charlotte. I know last year you had a video that you showed us, and then
would you like that again?
If you would like to show it, if you've got it ready, we can see the video.
I have it right here. I'm going to show you the one that talks about how to use the Narcan. Except give me 30 seconds.
Okay.
Am I still sharing my screen?
No.
Oh, darn. Hang on. I will bring it up.
And when you do share, remember to click the little box that says share sound, if there is any sound.
Okay. There is sound, share sound. Here we go. Okay. Now I just got to get it to play. Can you see it?
I see that you've started screen sharing, but there's nothing there yet.
Oh my goodness, it's asking me for a password, which is weird because I don't have this password protected. And it's not the right one. Oh, dang it. Let's do that. Let me see. I'm sorry, guys. I'm really sorry about this. Okay, can you see my screen now?
We can see it, and I see that there's a little button at the bottom that you can press for play, the little triangle.
I just want to make sure you can see it, and I'm hoping you'll be able to hear it.
Narcan nasal spray is an
emergency
treatment for a known or suspected opioid overdose. The appropriate use of Narcan nasal spray can help you save a life. Narcan nasal spray is not a substitute for emergency medical care. As with any drug, you need to be aware of important safety information concerning its use. If you encounter someone who is unresponsive and you suspect an overdose, first shake their shoulders and shout their name.
Kevin.
Ask if he or she is okay.
Hey, can you hear me?
Check for signs of an overdose. Unresponsive to touch or voice. Breathing is slow, uneven, or has stopped. Snoring, gasping, or gurgling sounds. Fingernails or lips are blue or purple. Administer Narcan nasal spray as quickly as possible if someone is unresponsive and an opioid overdose is suspected, even when in doubt, because prolonged respiratory depression may result in damage to the central nervous system or even death. Lay the person on their back to receive a dose of Narcan nasal spray. Remove Narcan nasal spray from the box. Peel back the tab with the circle to open it. Remove and review the printed quick start guide inside the package. Hold the Narcan nasal spray with your thumb on the bottom of the plunger and your first and middle fingers on either side of the nozzle. Do not press the plunger to test or prime the device. If you do, you will waste all or part of the dose of medication. Tilt the person's head back and provide support under the neck with your hand. Gently insert the tip of the nozzle into one nostril until your fingers on either side of the nozzle are against the person's nose. Press the plunger firmly to give the full dose of Narcan nasal spray. Remove the device from the nostril after giving the dose. After you have given this medication, seek emergency help right away. Narcan nasal spray is not a substitute for emergency medical care.
I'm with somebody who stopped breathing. I think they've had an overdose.
Move the person on their side after giving Narcan nasal spray. If possible, put their hands under their head and bend their upper leg forward. This helps prevent the person from rolling onto their stomach. This is known as the recovery position. Continue to watch the person closely. If they do not wake up or respond to your voice or touch, or if they do not seem to be breathing normally within 2 to 3 minutes, use a new Narcan nasal spray to give an additional dose in the other nostril. Acute opiate withdrawal symptoms may occur from use of Narcan nasal spray in patients who are opioid dependent. Symptoms include body aches, diarrhea, increased heart rate or tachycardia, fever, runny nose, sneezing, goosebumps, also known as piloerection, sweating, yawning, nausea or vomiting, nervousness, restlessness or irritability, shivering or trembling, abdominal cramps, weakness, and increased blood pressure. When the emergency is over, put the Narcan nasal spray back in its box and throw it away in a place that is away from the reach of children.
Okay. That video shows you how to administer the Narcan. Now, the other thing is I shared with Laura, the flyer, it's a PDF flyer that actually has a QR code on it where you can see essentially the same video. So if you ever want to see it again, she's going to send this out to you and you'll have it. It also has the copy of the instructions inside the packet. It's a one-stop shop for you. So is there anything else, Laura, that you would like?
Thanks so much, Charlotte. And we do have one question in the Q&A, and it's from Ms. Carmen. She says, what does the NCAP program support via insurance?
It doesn't cover, you have to have insurance. So you have to have your Blue Cross Blue Shield or whatever your insurance carrier is. It will cover $40 of your copay toward the purchase of the Narcan. Did that help?
Maybe. How much does Narcan usually cost?
I've only had one person ever tell me they had to pay anything above the $40.
Okay. And Carmen said, yes, thank you. That helped.
Thank you. Okay.
Okay.
Yeah, most people, there's no additional cost.
Okay. I know one question that I have that probably just goes against everything that people have been taught is when you said, don't worry about what they took. Like, don't worry about if it was cocaine versus fentanyl versus whatever drug. Do they all have different symptoms of an overdose, or is just the underlying symptom just not breathing, they're unconscious? That is it, because I think that's the hardest thing for people to get away from is what caused this. And
You know what? That's exactly it. They have opioid overdoses. They're not breathing well. That's the biggest, they're unresponsive and they're not breathing well. That is the biggest thing you're treating. We're not looking for anything else. The one thing we try to do is keep it very simple and very basic for everyone. And that makes it easy. I mean, they used to say, pinpoint pupils. And I'm like, if you're outside, guess whose pupils are pinpoint? Everybody's. So you can't go by that. And I've actually taken that out of any trainings that I've ever done because of that reason. I've had people tell me, well, I didn't give them Narcan. I know they're not breathing well, but their pupils aren't pinpoint. Okay. Just give them the Narcan.
Okay,
So-
that helps. So I think that would be the most difficult thing for me.
It is for a lot of people.
Okay, we do have another question that says, how many Narcan doses come in one kit? i.e. if a person doesn't respond to the first dose, is there another in the kit?
Yes. Each box comes with two
Okay.
doses, and each dose is 4 milligrams.
Wonderful. And I do want to put in another plug for the Western New York Rural Area Health Education Center. They are sending everyone that's on this training today a free Narcan kit. So as long as you added your address when you registered, we will have that. I will go through and verify that we have all of your addresses. So you may get an extra email from me, and then Charlotte will send those out within the next week or two.
Okay, and the next thing I want you guys to know, when you get your kits, please add gloves to it. We used to put gloves in them. However, not many people wear a medium glove. So we were finding a lot of them were getting thrown out. So we just say, get the gloves that fit you and put them in your kit so you'll have them.
Okay, excellent. I don't see any more questions at this time. So I do want to say thank you so much, Charlotte, for joining us today. I will send an email out to everyone with the resources that Charlotte talked about, another copy of the handouts, and information about your continuing education credits and the evaluation survey. We do value your thoughts and feedback, so please take 2 minutes to provide feedback on this session and any ideas you have for future sessions. So Christine and I will start planning for 2023 in a couple weeks, so let us know what you'd like to see for this series for next year. So thank you everyone for joining us, and again, thank you, Charlotte, so much. Happy retirement, and we hope everyone has a wonderful rest of your day.
Thank you.